Thank you for joining my presentation on sleep disorders and treatment options in pediatric patients. My name is Terrence Shenfield, and I am a former education coordinator at University Hospital, a major trauma center in Newark, New Jersey, as well as co-owner of A&T Lectures. I hope you enjoy this presentation, as you will learn a lot through it. I think you're going to enjoy today's presentation because I'm covering many different objectives. First of all, I'm going to describe the most common childhood sleep disorders. I'm going to then further describe normal sleep parameters in children, so this way you can identify what's normal and what's abnormal. Children go through different stages of sleep, and you may not know every stage, and so having a good handle on that can help you. I'm going to be describing the diagnostic criteria and treatment options for each of these disorders. I'm going to further talk about obstructive sleep apnea in children, and you're going to say, obstructive sleep apnea, I thought that was only for adults. But no, children sometimes have narrow palates. Sometimes children have enlarged tonsils or other hypertrophic tissue. So we're going to be talking about that. I'm going to describe sleepwalking. I'm going to describe nighttime arousals. I'm going to be speaking about nightmares and sleep terrors. And the final topic will be restless leg syndrome in children. By the end of this presentation, you're going to have a good handle on exactly what goes on with children in regard to sleep abnormalities. Sleep disorders in children and adolescents are very common. Even infants have sleep disorders. Many studies have shown that poor sleep quality and/or quantity in children is associated with a host of problems, including academic problems, behavioral problems, developmental problems, and social difficulties and other health problems. Not only do sleep pediatric patients affect child health, but they also can impact family dynamics and parental or sibling sleep. So it's not just the kid, it can impact the family. Children may suffer from problems falling or staying asleep. It could be physiologic problems such as obstructive sleep apnea. It could be disruptive behaviors during sleep such as sleepwalking or other parasomnias. It could be a whole host of problems. It could be restless leg syndrome. It could be daytime symptoms such as excessive sleepiness and others. So there's a whole bunch of things go along with children. It's not just for adults. It can impact children. While adults may suffer from the same problems, the underlying cause, presentation, and associated findings with children may be very different than those with adults. In addition, developmental aspects of childhood play an important role in pediatric sleep, such as in the cases of early childhood insomnias, adolescence delayed sleep phase syndrome. So this lecture is going to go a lot into different aspects of children, and especially the insomnias they have and reasons for that and treatment options. You might be surprised to learn that up to 50% of children experience some form of sleep problems. There are many consequences to sleep problems, such as daytime sleepiness, irritability, poor academic performance, learning difficulties, and for teenagers, there have been reports of people having motor vehicle accidents. And more surprisingly, you think of obstructive sleep apnea as being an adult disease, but up to 1 to 5% of children have obstructive sleep disorders. And then there's another thing called parasomnias. The term parasomnia describes a group of sleep disorders associated with unnatural movements, behaviors, emotions, perceptions, and dreams that occur while falling asleep, during sleep, and between sleep stages and upon wakening. So this is a very profound thing. It's called parasomnias. Examples of parasomnias are sleepwalking. It's more common with children than adults. There's REM sleep disorders. There's nightmares. There's night terrors. There's nocturnal sleep-related eating disorders and teeth grinding. These are all examples of parasomnias. The management of this begins with the implementation of good sleep hygiene practices. We really need to have some good sleep hygiene practices. And in some cases, They may prefer using extinction techniques, which may be more appropriate. And I'm going to get into exactly what is extinction techniques. Delayed sleep phase disorder is most common in adolescence, and it probably presents most commonly with difficulty falling asleep and awakening at socially acceptable times. There's actually a shift in phase with adolescence with the circadian rhythm, and I'll talk a little bit about that later too. Also, restless leg syndrome in children can be difficult to diagnose, and the management of that is to avoid triggers, and there are certain other options you could do with that, which we'll talk about. So, it's very common in children to have sleep disorders. I just listed a whole bunch of conditions that can occur: the parasomnias, the obstructive sleep apnea, the restless leg syndrome, just to start. And the best way to manage this is good sleep hygiene practices and extinction techniques, which we're going to talk about a little bit later. So let's get into some basics. Why do we really need sleep? Sleep is an opportunity for the body to conserve energy, restore its normal processes, and promote physical growth, and most importantly with children, support mental development. The most recognized consequence of inadequate sleep is daytime sleepiness, but it could manifest itself a little bit differently with children. When children don't have good night's sleep, they end up being irritable, they have behavioral problems, they have learning difficulties, and a lot of times they have poor academic performances. So it's really important to get some good sleep. Sleep changes considerably during the first few years of life and parallels physical maturation and development. So as a child gets bigger, so does the sleep pattern change. Starting at about 5 months of age, infants have the ability to sleep for longer periods of time than children. And then about 6 months of age, children have the ability to go without nighttime feedings, and they can sleep, all through the night. There's changes in time, age-related changes in sleep patterns. Over the years, sleep patterns definitely change as someone gets older, but a large variation in sleep behavior amongst children may be secondary to cultural or genetic differences. For example, different cultures have different sleep patterns than what we see here in America, so you have to sometimes take that into consideration. Ultimately, knowing the normal development stages of sleep will help differentiate between normal sleep and common sleep disorders such as obstructive sleep apnea, parasomnias, behavioral insomnia of childhood, and different types of sleep illnesses. So, knowing sleep, knowing your child is growing, understanding the different aspects of growth is a very helpful thing. This is a nice summary slide that talks about normal sleep parameters in children. And it's broken down into a category of age, total sleep time, and if they take naps on the average. So, for example, from ages 0 to 2 months, the total sleep time required by those individuals is 16 to 18 hours, and they could take anywhere from 3 to 4 naps a day. Ages 2 to 12 months, that's normally about 12 to 16 hours a day, and they could take about 2 naps a day. Ages 1 to 3, 10 to 16 hours, 1 nap a day. Here's where it gets a little odd. The 3-year-old to 5-year-old sleeps an average of 11 to 15 hours, but only about 50% of them actually take naps. So if your 3-year-old doesn't take a nap, don't think that there's something wrong with them. That's the way it is. You got the 5 to 14-year-olds. They typically need anywhere from 9 to 13 hours. There's a little discrepancy between nap time for white children versus black children. It seems like black children take naps a little bit more often than the white children, but there's nothing abnormal about that. That's fine. In the ages of 14 to 18 years of age, there's a shift in the circadian rhythm of sleep, and they normally sleep 7 to 10 hours. But a lot of them, if you see them napping during the day, it's because they have insufficient sleep. And this is something you got to recognize. The circadian rhythm of a 14 to 18-year-old is a little bit different than an adult, and it's also different from a child. So you might be, keep an eye out for that. I'm not going to talk much about that, but there's something to that. So in today's presentation, I'm going to cover many topics that are part of the common sleep disorders in children. I'm going to be talking about obstructive sleep apnea. Obstructive sleep apnea is not just for adults, but typically the reason for the obstruction is different, and we're going to get a little bit more into it. We have parasomnias. Now, parasomnias can include sleepwalking, confusional arousals, sleep terrors, nightmares, behavioral insomnia of childhood, delayed sleep phase disorders, restless leg syndrome. All of these are parasomnias. So we're going to get a little bit into each one, and hopefully by the end of the presentation, you'll have a clear understanding of the disorders that are common with children. Let's talk about obstructive sleep disorders in children. And it's no surprise that some children benefit from nasal CPAP in conditions. Some children benefit from nasal steroids. They have a bunch of different devices that they can use. Some require surgery. And we're going to get a little bit more into that. But I can imagine the compliance rate of a child with nasal CPAP is probably much worse than an adult. So I'm not sure of the exact statistics, but let's talk a little bit about obstructive sleep disorders in children. So let's talk about the prevalence of obstructive sleep apnea. It occurs about 1 to 5% in the childhood population. The normal onset is between the ages of 2 and 8 years of age. It impacts males more than females. It's more common with Black children, those with craniofacial abnormalities. When I say craniofacial abnormalities, there are some children who have a narrow palate, or they could actually have enlarged tonsils or other hypertrophic tissue in the neck. So these craniofacial abnormalities can be part of the problem. The common clinical features you see with this is snoring, paradoxal breathing, morning headaches, enlarged tonsils and adenoids. And patients with pectus excavatum have been shown to have an increased likelihood of getting obstructive sleep apnea. And the reason for that is laryngomasia. In other words, the larynx is actually morphed in size and change as a change in directions, and this actually causes obstructive sleep apnea. So these are the common things you see with sleep apnea in children. Obstructive sleep apnea, diagnostic criteria, and treatment. Polysomnography is required for the diagnosis of obstructive sleep apnea if you have an AHI of greater than 1.5 times per hour. The first line treatment of obstructive sleep apnea in children is adenotonsillectomy. And what that means that they have their adrenal glands and their tonsils are enlarged, and they really need to be surgically removed. The downside to that is only about 25% of them have a complete response to the therapy. So they do the surgery and only about 25% of them respond positively. The mainstay for obstructive sleep apnea in adults as well as children, and also for overlap syndrome, is CPAP. Continuous positive airway pressure is the best thing in the world. But another good choice is nasal steroids. They did a study in a prospective randomized double-blinded trial. They looked at 25 children with mild to moderate overlap syndrome who were treated with a 6-week course of either nasal steroids or placebo. What they did, the authors demonstrated a moderate improvement in sleep disordered breathing with nasal steroids, and the AHI decreased from 11 times an hour to 6 times an hour. So nasal steroids is a very good choice, rather than going right to surgery, and CPAP is a good choice. But the first line of treatment is surgery, and like I said, there's only about 25% have a complete response. They also have what is known as maxillary expansion devices, and they only found that only about 10% of the children actually need this and benefit from them. So I have a nice picture of what a maxillary expansion device is on the next slide. This is an image of a maxillary expansion device that goes in the mouth of the child. As you can see, it looks rather uncomfortable, and most of the time it works for patients who have a narrow palate. Only about 10% of all children actually qualify for this, so this is a good idea what it looks like, and it actually expands the airway so the obstruction is alleviated. Another pediatric disorder with sleep is sleepwalking. And I personally don't know anyone, or anyone I know who has children who sleepwalk, but it is quite common. It normally occurs between children of the ages between 4 and 8, but there's some other age groups that occur. What happens is the child falls asleep, and about an hour or two later, they wake up and they sleepwalk. They don't remember what's going on. And they do this, typically the episodes last anywhere from 5 to 15 minutes. And typically this is a harmless type of thing, unless the kid can be subject to getting hurt and tripping or something like that. But it can be dangerous, and you should understand a little bit more about it. They were wondering what causes sleepwalking, and there's a whole host of things. They really can't pinpoint exactly what's going on with it. A family history of sleepwalking is really important. If you have a family history of people sleepwalking in your family, so there is a genetic component. If the child is fatigued or has lack of sleep, that can cause it. If they have irregular sleeping habits, that could cause it. Anxiety, stress, being in a different environment, all of these type of things can cause sleepwalking. Even certain medications such as sedatives and stimulants and antihistamines can form some kind of sleepwalking process. So I'm going to get a little bit more into it. I just wanted to introduce it to you, and then we'll move on. The prevalence of sleepwalking in children is approximately 17%. In adults, it's about 4%. Typically, sleepwalking disappears when the child reaches puberty, or when they get a little bit older. The typical peak ages for sleepwalking is anywhere from 8 to 12 years of age. Is more common in males, and there is a genetic component to it. If one of the family members has a history of sleepwalking, there's a 45% risk. If two of the parents have it, it's a 60% risk. I'm going to get a little bit more into sleepwalking on the next slide, but this is just a quick overview. The diagnosis of sleepwalking is typically made by history from the physician and not a polysomnograph. Generally, it occurs in deep, non-rapid eye movement, stages 3 and 4 sleep. Typically, sleepwalking will resolve itself when a patient reaches puberty, and that's the most common thing. When a patient reaches puberty, it typically stops. Now, some of the treatment options you could do with the child is you could increase their total sleep time. As I mentioned before, sometimes kids who have fragmented sleep or overly tired, that's when they get it. So they would benefit from an increased program where it gives increased total sleep time. Sometimes you got to do scheduled awakenings during the night. If things get really bad, you got to wake them up so they don't go into this, and just let them go to sleep. Another thing is home safety counseling. If you have your child's bedroom up on the second floor and there are stairs going from the first floor to the second floor to the kitchen or to the living room, maybe you might want to reposition that that bedroom, or you want to move the bedroom to a different location. You got to do something to protect the child because they don't remember what's going on. Pharmacologically, benzodiazepines are sometimes offered to this group of children if they have, certain, conditions that warrants them taking it. But these are the typical treatment options, and this is typically they outgrow it when they reach puberty. So what is confusional arousals in children? Basically, this is a sleep disorder that causes you to act in a very strange and confused way when you first wake up. It appears that you don't know where you are, you don't know what you're doing, your speech is a little bit off, you have confused thinking, you have poor memory, you might even have a blunt response to your parent asking you questions like, are you okay? You might just, look at them kind of weird. Typically, it's a lot of patients who have confusional arousals also have sleepwalking. It is considered a parasomnia, and this type of sleep disorder involves unwanted events or experiences that occur while you're falling asleep. So basically, it tends to occur when you wake up from slow wave or stage N3 sleep. In rare cases, adults can even get this because you could act inappropriately and then you could actually be aggressive. Children also have been known to be aggressive during this state. So this is called the confusional arousals in children, and I'll get a little bit more into it in the next slide. The prevalence of this disorder is around 17% in the age group of 3 to 13-year-olds, and about 3 to 4% in older adults greater than 15 years of age. It equally occurs with males and females. Genetics plays a key role in this. If one of your parents or both of your parents have a history of this, there's a good likelihood that you might have it. Typical signs of confusional arousal is that you appear like you're almost like drunk when you wake up, like you're confused or inappropriate. You have a slowed response, you have a slurred speech, and typically this occurs during the first half of sleep, and typically children don't remember what happened. So this is a typical sign of confusional arousals. So how do you diagnose confusional arousals, and what are some of the treatment options? Typically, the diagnosis is done by history of the patient, especially a family history where one or more of the parents actually has this type of disorder. Polysomnograph is not required in these cases. It usually resolves spontaneously. So as the kid gets older, the amount of confusional arousals will decrease. Some of the treatment options include increased sleep total time, meaning the longer someone has to stay in bed and go to sleep, even though they may not be in REM sleep, the more likelihood they'll get adequate sleep. Another common treatment plan is to do what is called scheduled awakenings. Now, I wanted to get a little bit more detail into what is scheduled awakenings and how it's used. And it's used for a host of disorders such as sleep terrors, sleep talking, sleepwalking, and arousals. So scheduled awakenings is a very common method and it's quite effective. Basically, the goal is the child is really not awake during the time. So while these incidents occur, they're really sort of half sleeping. So they may not even remember what's going on. And the goal is you want to sort of wake them up prior to them going into these events. So before they become sleepwalking or sleep talking or grinding their teeth, you want to wake them up. And how you do that is you keep track of your child's sleeping pattern for 2 weeks. You should record the bedtime, what time they go to bed, what time they wake up, and more importantly, the timing of these parasomnia events. Once you have a consistent pattern and you see what it is, what you do is you look at the average time that the child has this sleep terror. What time does this naturally occur? And the goal would be to wake them up. And when I say wake them up, I don't mean actually get them out of bed. I mean just gently nudge them. And so you get them out of this stage of sleep and they become awake, and then let them fall back asleep. This has been proven to be quite effective. It's called scheduled awakenings, and it's a very good therapeutic way of managing a bunch of different sleep disorders. But you got to do your due diligence and really monitor their sleep patterns. And then the idea is just wake them up or gently nudge them, and they won't even remember this whole thing. Typically, you could break the cycle and they'll sleep better, and they won't have the terrors, they won't have the confusional arousals, and they'll be in a better spot. Also, what you need to do is implement home safety counseling, meaning that, while these events are occurring and they could potentially hurt themselves, you got to sort of clear the bedroom of any kind of harmful things like, toys on the floor. If they happen to get up out of bed, you don't want them tripping over any kind of furniture or any kind of toys on the floor. So home safety counseling or bedroom counseling is really important to sort of make the environment safe for them. But, now that you know what scheduled awakenings are, you're going to find that this is a common treatment option for many children, and also increasing total sleep time is another option, and we'll get a little bit more into that later. So let's talk about sleep or night terrors. Night terrors are characterized by screaming, extreme distress, autonomic arousal, increased body movements, and sometimes sleepwalking. The kids can trash around the bed, they could kick their legs, they could swing, they could punch, they could be potentially dangerous. This impacts around 3% of children, and the sad part, it occurs nightly. People who normally have night terrors have them every night. The good news is the child does not remember. The episodes arise in slow wave sleep, stages 3 and 4, and normally within the first 2 hours of falling asleep. And then typically when the child transcends from slow wave sleep, stage 3 and 4, to REM sleep, that is when this occurs. The child cannot be confronted, it cannot be woken, it has no memory of what's going on, and typically there's no kind of psychiatric disorder to this, but you might think there is because of the behavior. There's a wide range of treatment options going along with them, including benzodiazepines. The thing is, potentially a lot of these children outgrow this when they reach puberty, but some adults even continue to have sleep and night terrors. Pretty severe. The prevalence of sleep terrors is anywhere from 1 to 6.5%. That's the range, but the average is around 3%. And even some adults, approximately 2% of adults, continue to have night terrors. Typically, the onset of this disorder is early in life. It impacts males and females equally. How it manifests as an intense fear, such as screaming, crying, confusion. A lot of times they trash around the bed, they cry while they're sleeping. Kind of scary to look at. You might think there's something psychiatric going on, but really nothing really is going on there. It's difficult to awaken someone from these episodes, and it could potentially be dangerous. So, you have to have some room safety going on. You can't have things laying around that could potentially harm you or someone in the room with that. Usually they wake up and they don't remember a thing. And I got some decent treatment options that are out there, and I'll show this to you on the next slide. Let's talk about the diagnostic criterion treatment options. Typically, diagnosis is done by history. You get some history from the parent who talks about the child's awakening and behaviors. You could also look at family history, like any kind of genetic history to it. Polysomnogram is really not required in this. Some of the best known treatment options is to increase total sleep time. What that means is the patient stays more time in bed so they could go through different stages of sleep, and overall they benefit from it. Also, scheduled awakenings, and I went into a lot of detail on the previous presentation of what scheduled awakenings are, but this has been shown to be quite effective in this group too. Sometimes none of those work and you need to introduce some kind of pharmacologic therapy, and benzodiazepines are the mainstay therapy for that. But typically you really don't want to put sedation on board. Usually it resolves spontaneously. Like I said, there's a small percentage of adults that continue to have that, but once a child reaches puberty, typically it resolves itself. So let's talk about nightmares. So you may ask, what's the difference between sleep terrors and nightmares? The difference between a nightmare and a sleep terror is in a nightmare, you could wake up and remember some of the details of your dream. But as a night terror or sleep terror, you do not remember any of the episodes going on. Typically, children don't remember anything about their sleep terrors in the morning, but nightmares, they do remember. Nightmares can occur at any age, but suggest that they are exceptionally common amongst young children. Roughly half the children between the ages of 3 and 6 report frequent nightmares. The same is true for 20% of the children between the ages of 6 and 12. So obviously, the younger children, 3 to 6, have more nightmares than the older group. Nightmares never go away because even as adults, we end up having nightmares. While most children eventually outgrow their nightmares, some develop what is known as nightmare disorder, a condition characterized by recurring or unpleasant, frightening dreams that cause sleep disturbances. As a guide, the root cause behind children's nightmares at different ages, and you can discuss different strategies with the children and their bad dreams. So how do nightmares affect children? Nightmares primarily occur during rapid eye movement or REM sleep, the final stage of normal sleep cycle. REM sleep is more prevalent during the middle of the night or early morning, so children are more likely to wake up from a nightmare at these times. So we're going to get a little bit more details about nightmare, how to diagnose it, and how to treat it. But nightmares are a pretty common thing amongst children and even adults. The prevalence of nightmares is anywhere between 10% and 50% in the age group of 3 to 5. Onset typically takes place at that age group and peaks around the ages of 6 to 10 years of age. There's a strong genetic component with this. Studies have shown that parents who have nightmares, uncles who have nightmares, aunts who have different family members who have nightmares, there's a strong genetic predisposement of that you'll get it too. Typical symptoms include very unpleasant dreams. When you have these unpleasant dreams, you have a strong sympathetic response. What is a sympathetic response? That is an increased heart rate, increased respiratory rate, diaphoresis. You're almost jumping out of the bed. Your heart rate goes up, your blood pressure goes up, everything goes up because that's a sympathetic response. If you wake up from this, you actually remember the dream. So you might have some post effects as a result of that. It normally occurs during the second half of sleep, and typically the child definitely remembers the event. A lot of times once a child wakes up from the nightmare, they're reluctant to go back to sleep because they're afraid they're going to go back into nightmare again. It's definitely associated with mood disorders and post-traumatic stress disorder. A lot of studies have shown that adults with post-traumatic stress disorder have severe nightmares. This is one of the few sleep issues that they believe has a psychiatric component. And I'm going to get a little bit more into it as we go along. The diagnostic criteria and treatment options for nightmare: diagnosis is made by history. So the physician will sit down with the patient, get a history from the patient as well as the family member, and they'll have a strong idea of what's going on. Polysomnogram is not required. Some of the treatment options, and we're going to get a little bit more into this as we go along. Nightmares can be treated by increasing total sleep time. I've talked to this process before. Also, scheduled awakenings. When the kid goes into before they go into nightmares, there's normally like a pretty routine schedule. You could do some scheduled awakenings with them. Obviously, you have to do some bedroom home safety counseling. You got to make sure the bedroom's safe because there's a sympathetic response. You could jump out of bed, crying or running for your mom or dad, whatever you got to do. Some of the good treatment options out there is cognitive behavioral therapy. And my next slide is going to be talking a little bit more about that. In regard to medications, you want to take medications that suppress rapid eye movement, and one of the better choices are selective serotonin reuptake inhibitors, which seem to work very well in suppressing rapid eye movement. So our next slide, I'm going to talk about different facets of cognitive behavioral therapy that is used for patients with severe nightmare. So let's take a stab at cognitive behavioral therapy, commonly known as CBT, for nightmares. Cognitive behavioral therapy is a therapy that is utilized for a host of disorders that go along with patients. In particular, they have a special type of set of behavioral therapies for people who have recurrent nightmares. So if you have a child that has the same type of nightmare, that they're being chased by a two-headed horse or whatever, or a monster's coming into their room, cognitive behavioral therapy is a way of treating the child. The emphasis of cognitive behavioral therapy is that individuals help themselves. In other words, it's almost a self-fulfilling type of therapy where you as the patient are very much in charge of the behavior that you try to do to decrease the nightmares. Now, I am not a psychologist. I am not a psychotherapist. And if you ask my wife, she thinks I need to see one, but I'm not going to do it. But let's go on. So these are different aspects of cognitive behavioral therapy. One of them is called IRT, or Imagery Rehearsal Therapy. And what this does is basically when the child wakes up from the nightmare, this recurring nightmare, and while they're awake, they want to talk about what exactly happened. And they want to write down exactly what happened. They want to script it. In other words, they want to almost write the story of what happened during that unpleasant event. But what they want to do is change the ending to a more satisfactory one. In other words, at the end, they chase the monster away. So in other words, they script their own dream. When they have that nightmare, they write it down because most of the time they can remember it. And then they write it down and they try to imagine that they change the outcome of that. The second one is called exposure techniques. And exposure techniques consist of gradually exposing the patient to the source of the negative part of the nightmare during the wakefulness and in a safe surrounding. So, for example, suppose a child's afraid of dogs, and they always think they're being chased by dogs. What you can do with this child is bring them over to a friend's house who has a little pet, a very safe pet, and expose them to the dog that, the dog is kind and everything like that. Obviously, this takes a little time, but that is called exposure techniques. Another technique is called exposure relaxation rescripting therapy, or ERRT. During this time, you want to educate the child about what they were dreaming. You want to talk about sleep hygiene. You want to talk about progressive muscle relaxation. And you also want to utilize that rescripting the nightmare So basically, you want to re-script the nightmare or redo the nightmare that you come out ahead and that no monsters chase you. Finally, we get into what is called lucid dreaming therapy, or LDT. And basically, this is a restructuring technique where the patient is taught to become lucid in his nightmare through daily exercises. So in other words, while they were in their nightmare, while they were in their dream state, they changed the outcome right then. Kind of interesting. And then finally, you got hypnosis. They call it hypnosis, eye movement desensitization and reprocessing, EMDR. And basically, this is a new line of therapy. And, there's not much out there. There's some new studies coming out there, but, they're looking at using hypnosis for managing nightmares. So, like I said, I'm not a psychologist. I did my best I can to explain the different techniques they use, and we'll move on. Now we're on to section of behavioral insomnia of childhood. Don't you just love a child that doesn't go to sleep or climbs out of the crib or insists that they sleep with mommy and daddy, or that you read a story to them before they go to bed, or that they sleep with their favorite animal? These are behavioral insomnia of childhood, and I believe every child in the universe at one time or another has this. Children, especially under the age of 2 years of age, normally have a hard time falling asleep on their own or return to sleep when they wake up unless special conditions occur at their bedtime. For example, they may be used to having their favorite toy next to them, being rocked to sleep, or having a parent sit next to them till they fall asleep. This process can be very demanding to the child and the parent at the same time. It may be the wrong way of going about it. The second type is children stall or resist to going to sleep at appropriate times. So you tell your child it's 8:30 p.m., you need to go to sleep, and they say, no way, get me a glass of water, I have to go to the bathroom, I forgot to brush my teeth, so on and so on. The children may ask to hear bedtime stories. They may want some other type of attention. If they wake up once while they are sleeping, they may refuse to go back to bed. This usually starts around 2 years of age, and these children can be quite verbal about what they want and climb out of bed. So, behavioral insomnia of childhood, pretty common. How we deal with it is a different story. Behavioral insomnia of childhood, the prevalence is anywhere from 10 to 30%. It impacts males more than females. And some of the symptoms are difficulty in initiating or maintaining sleep. They don't want to go to sleep at the right time. They don't want to stay asleep. Frequent nighttime awakenings are very common. Falling asleep is delayed, and they are very demanding on parents. These are the children that drive the parents nuts, who end up taking the kid back in bed with them. This causes significant parental distress. I think all parents at one time or another had their child in the bed with them. When they need to go to bed, they refuse. They have all kinds of installing techniques, such as, I have to go to the bathroom, I have to brush my teeth, you need to read me not one story, you need to read me 5 stories. Also, parents fail to set boundaries with these kids. In other words, a lot of this has to do with the parents' control, what they do and how they teach the children. And you need to set boundaries. When bedtime is bedtime, you need to do what you got to do. So this is a little bit about behavioral insomnia of the childhood, and I'm going to get a little bit more into it. The diagnostic criterion treatment options for behavioral insomnia of childhood is many. The diagnosis, again, is made by history. Polysomnogram is really not required. Treatment options vary, and I'm going to get a little bit more into it. They consist of prevention. They speak to parental education, because a lot of parents, especially new parents, don't know what to do with their child. And sometimes they should listen to their parents who, had experience. And then finally, we'll talk about extinction techniques. These are all strategies that can be used to treat behavioral insomnia of childhood. Wah, wah, wah. You hear a crying baby. What do you do? What do? You run back in the room and take care of the baby? Do you take them in bed with you? So one of the best strategies out there to deal with the baby and developing a good sleep routine with them is called extinction techniques. And extinction techniques, there's unmodified, there's graduated, and there's extinction with parental presence. I'm going to talk a little bit about each one. In regard to the unmodified extinction, this is known as the cry out. Basically, once completing the normal bedtime routine, you allow the child to go back to sleep on his own. If the child makes extra requests beyond the routine and begins to cry, you don't pay attention. You ignore it. You need to ignore your child until the time you get them up in the morning, unless you believe your child is hurt, they're ill, or they're in danger. In other words, you got to shut down. You cannot go back into the room, and eventually the child will fall asleep on their own. This technique can sometimes be required to repeat. In other words, it may last for a little bit, but then it falls back into a routine where you go in and you help the child. This is called an extinction burst. When this happens, you need to go back in and do exactly what you started to do. You put the child to bed, you make sure the child is safe, you make sure the child is not ill, you make sure that the child is dry, you put them in the bed, you give them a kiss, and then you leave. When they start crying, you don't respond. The next time they see you is in the morning when they wake up. That is called the unmodified extension, and it really works pretty good. The next one is called graduated extinction. This is also called controlled crying or sleep training. What happens then, you put the child to bed and you leave the bedroom. You should ignore the kid's cries for at least 10 minutes. If the kid keeps on crying after 10 minutes, you could walk back in the room, but you do not pick up the child. You just tell the child go back to sleep, and you comfort them with they see you. But then you go leave the room again. And you could go back to the room every 10 minutes in this kind of process. This is called graduated extinction. And finally, we have extinction by parental presence. What this means is you're camping out with the child. You stay in the room with the child, but you do not sleep in the same bed with the child. You may sit on a chair, and if the child comes to you and complains that they're hungry or they're thirsty or need to go to the bathroom, you ignore them, but you're still in the room with them. So those are the three methods that you may use with children to go to sleep. I don't know which one works better than the other. When I had children, I can't remember, but I think I was more or less the unmodified extinction method, where you just put the child in the room and then you battle with your parent, the wife, because she wants to go get the children, or you battle with the dad because he wants to go get the kid and thinks something's wrong. So these are called extinction techniques, and they have worked for centuries. Okay, now we're going to be talking about delayed sleep phase disorder. Basically, this is a disorder that is mostly impacted by the circadian rhythm of the body. So the circadian rhythm, which is a natural rhythm of your body to go to sleep and wake up, is altered. And it could be altered by up to 2 hours. So versus conventional sleep patterns, you might think, what the heck's going on? Why does this kid want to not get up in the morning? Or why don't they want to go to sleep at night? It mostly impacts adolescents. And studies have shown that this is very common amongst teenagers, because teenagers like staying up late. And it's, you can't really blame the teenager because a lot of times these teenagers want to stay up late because they're not really tired. And then because of the way school systems work, that they have to catch a bus in the morning or they have to walk to school, they have to get up at the crack of dawn. So a lot of times these kids are kind of grumpy in the morning, and it's really not their fault. They're going through puberty. They have a shift in their circadian rhythm, and this is what's causing what they call a delayed sleep phase disorder, and it does go away in time. The prevalence of this disorder is around 7 to 16% in adolescents. The onset is typically found with adolescents and peaks around the age of 20, almost the years that they go through puberty. And once they reach the age of 20, they become somewhat normalized. 40% of those infected have a family history of this condition, so there is definitely a genetic component. The problem with this, the symptoms, they have a hard time initiating sleep at a normal routine. So you try to put them better a normal time, like you would expect them to go to sleep like you, and they're not tired. They have frequent nighttime awakenings, are very common. It's very demanding on the parents because you can't stay up to 1 o'clock in the morning letting your kid go to sleep when you got to go to work the next day. It's a problem. It causes significant parental distress. This time of the life, besides them being teenagers, they have this phase disorder with their sleep, and that further exasperates being a parent. Bedtime refusal or stalling techniques, these are common things. Typically, it's not a childhood thing. It's more of an adolescent thing. And also, this could be a problem with the parents if you don't set boundaries. Setting boundaries with your children is really important, and sometimes parents don't do that. Our final topic today will be on restless leg syndrome, commonly known as Willis-Ekbom disease. It is a sleep disorder in which the child or adolescent reports an uncomfortable or an irresistible urge to move the legs. This urge normally happens at bedtime, but it can occur anytime during the day when the legs are inactive. To relieve the discomfort, the child will move their legs, stretch their legs, toss and turn, get up and walk around, and when this happens, the relief is immediate. They feel 100% better as soon as they do any of the above. It impacts a lot of children in the United States, and excuse me, the exact cause of this varies from child to child. In some cases, the cause is not known, but in other cases, it could be due to a low iron level. It could also be associated with diabetes, kidney disease, or neurological diseases. It typically runs in the family, so there's definitely a genetic link there. And it can be treated with many different drugs, and sometimes certain medications can cause restless leg syndrome. So the things that go along with it, you have leg discomfort, you have the urge to move your legs, you have sleep disruption. Because you keep on moving your legs, you keep on waking up. You had bedtime behavioral problems, probably most manifested because you're uncomfortable. You have daytime sleepiness because you can't sleep good. And then sometimes you may have school performance issues because you don't sleep well. So this is restless leg syndrome. We're going to go a little bit more into it on the next slide. The prevalence of restless leg syndrome is approximately 2% based on some studies. It's more common in women than it is with men or boys. Family history is very important because there's definitely a strong genetic component. The typical symptoms are the urge to move the legs because you're uncomfortable. You feel pain, you feel discomfort, so you want to move your legs. Sometimes you get up out of bed and it goes away, then you go back to sleep, but this is what causes that fragmented sleep. It also can be associated with iron deficiency, as I mentioned before. A lot of times because you don't sleep well with restless leg syndrome, you could have some negative behavior because you're tired and you're moody. Also, you could have decreased cognition and attention span. And a lot of times, those with restless leg syndrome also suffer from attention deficit hyperactivity disorder. So there is some kind of correlation there. So let's talk about the diagnostic criteria and treatment options. First of all, diagnosis is made by history, right? A polysomnogram may be indicated to determine if you have periodic limb movements. Many times the child really can't describe exactly what's going on, and it's misdiagnosed. But if you have any of the two present, such as a sleep disturbance or a first-degree relative who has a condition, or you have 5 or more periodic limb movements per polysomnogram, yes, you might have restless leg syndrome. Treatment includes avoidance of nicotine and caffeine, discontinuing certain medications such as antihistamine, selective serotonin reuptake inhibitors, and tricyclic antidepressants are all they can cause restless leg syndrome. Also, a lot of patients have iron deficiency, so iron replacement therapy may be necessary. In severe cases, a dopamine agonist, gabapentin, and benzodiazepines may be required for these particular patients. In summary, sleep disorders in children may not be recognized. You may just think that this is normal behavior of a child, but understand that sleep disorders do exist with children, and the sooner you understand what's going on, the better. You should identify your child's behavior and make sure that you're not part of the problem. In other words, if you don't set boundaries about sleep time and sleep hygiene techniques, you can't blame the child. You could blame the parent. If you take the child to bed with you every night and the child ends up having some kind of sleep disorder, you're the cause. Treatment options vary based upon diagnosis, so understand the treatment options. Surgery and CPAP for OSA may be indicated, but not all the time. As I mentioned, surgery is effective in 25% of the patients who get it. Good evidence is available on the web. There's a lot of studies out there, so if you really are interested in learning more, I request that you go read it. It's a lot of good information, and I want to thank you for joining me. So this is my reference page. If I have more references if you want it, but I thought these would cover it pretty good. These 4 studies that I looked at were very good for getting a good understanding about sleep disorders in children and adolescents. And I want you to have a great day, and I want to thank you so much for joining me. You all guys take care.